part being treated and place it in the patient's axilla with your thumb just distal to the joint's margin anteriorly and fingers posteriorly.
Pause there. Give me my hand position one more time.
So use the hand near the part being treated and place it in the patient's axilla with thumb just distal to the joint, margin anteriorly, and fingers posteriorly.
Perfect. So we're gonna cradle the upper extremity. And I don't remember if this is a bullet point or not, but remember when we're doing joint mobilization, the patient's gotta be relaxed. If the patient's holding their arm up on their own, what's his rotator cuff doing? It's contracting. If it's contracting, what's it doing to the joint? Stiffening. It's adding compressive stiffness. We don't want that because I'm trying to pull it apart. So we need to make sure the patient's arm is as relaxed as possible. So take it, cradle it nice and tight in here. We're going to support down here as well. I think there's a bullet point coming up about this. And then the mobilizing hand is going to be right in here. Fingers behind, thumb up front. And we're using the web space right there in the axilla. All right, keep going.
That's correct. The next sentence
Thank
says support the forearm between your trunk and elbow. Next bullet point, your other hand supports the humerus from the lateral surface.
Good. So we're going to be posterolateral here. Posterior, just so they feel like they don't have to hold their arm up. I want to have the arm as supported as possible. And lateral, because in a minute I'm going to give some force this way. So right out here.
So next section is mobilizing force. With the hand in the axilla, move the humerus laterally.
Perfect. Now, laterally is an easy word to read, but it's not truly a lateral force. I'm not going toward like Brennan's badge. That would be perfectly lateral. Instead, I need to see a treatment plane and go like up toward where the ceiling meets the wall over there. I need to make sure that my force is in scaption, 30 degrees anterior to the frontal plane. So my force is going to be right here if I was to move the arm. Okay?
Do you want me to read the note?
I don't think so. Okay, so here's my force. I'm going to use my elbow on his torso to kind of get a little anchor point. This way I can do this and I'm not just trying to pull here. I'm going to anchor on the torso. I'm going to be mobilizing this way and giving just a little bit of counter pressure here on the distal humerus so that I'm directing the force into the joint space. If we go really small, it'd be a grade 1. If we go big, it'd be a grade 2. If we were to go all the way to end range, we would get to grade 3 and 4, but day 1 at the shoulder, let's keep it early in the range so that nobody ends up going home feeling unhappy. All right, so that's good. Okay, we want to make sure the upper extremity is as limp as possible. If you look over and you see your patient making a fist, I know right away that his rotator cuff is active. I need limp noodle. We want to have him as relaxed as possible. Cradle the arm and support it here. I want him to feel as relaxed as he can. All right, it's a relaxed arm. We're not perfectly in the loose pack position. I'd be up here if I was to get him there. It'd be a tougher mobilization. So he's not quite in the loose pack position, but he's close. You'll see kind of the same in the image. I'll take my arm and just support it on his torso. Gives me an anchor. Lets me push off of something. Take the hand and we're all the way in the axilla. If you're ticklish, this is not the most pleasant one. Okay. So thumb above, fingers below, or fingers posterior. And we're given the force with our web space in this direction. A little bit of counter pressure here. And we're being really gentle today. Can always add more next time. If, you just roll your sleeve up.
Absolutely.
Sometimes, depending on your patients, I think we'll see it with a few folks in here, you can see a little bit of the separation occurring as the humeral head moves out away from the glenoid fossa. We'll go a little further so that we maybe see some with you. might see it with really gentle force with some of the folks in here. So again, grade 1 and 2s, neutrify the cartilage if it's been immobilized, good for pain and guarding. If we were to go to end range, 3 and 4s, it's good to improve capsular mobility. It's a whole lot moved, right? In between the patient and his or her arm cradled, as close to the resting position as I can get the arm. And how are we sitting? It was a great description.
One cheek on, one cheek off.
Yeah, that's really good.
The best I remember it.
Perfect. Mr. D, that's going in the book.
One cheek on.
Trademark it.
Yeah. See if you're gonna put stuff on our TikTok. There you go.
One hamburger with one bun. All right.
All right, Joe. Where are you reading from, just so everybody can know? We're on the top of 147, left column.
Yes. All right. Under therapist position and hand placement, stand with your back to the patient between the patient's trunk and arm. Support the arm against your trunk, grasping the distal humerus with your lateral hand. This position provides grade 1 distraction to the joint.
Pause there. So with this, I'm just giving a little bit of a force in this direction to unweight the joint surfaces. Again, if I can do my slide or glide with just a little bit of a distraction, I should have a more comfortable, more effective technique. So pull in gently, and then he's going to be back up. Yes, sir.
A question for our little hands individuals
Yes.
here. How would you place your hand?
Yeah, that's a great question. So it's obviously we're not getting around the whole arm here. Use the epicondyles. If you can get your arm around here and get onto the medial and lateral epicondylar area, they give you a great anchor. This way you're not just sliding on the skin. Grab the epicondyles and just lean back a little bit.
I didn't even think of that. And I'm doing the small hand.
Place the lateral border of your top hand just distal to the anterior margin of the joint, with your fingers pointing superiorly. This hand gives the mobilizing force.
So this hand is going to be as close to the joint space as possible. You want to make sure you're not on the coracoid, but truly on the humeral head, the most proximal aspect. Now, some people have kind of irritable biceps tendons. So patients, the most valuable feedback we get is from you as a patient. If it's uncomfortable, tell the person you're working with so they can fix their hand placement now, but try to make the palm of your hand, the heel of your hand, as broad of a surface contact as you can, so that you're not just giving a force with like one finger. Spread out those forces so that you're applying it to the whole proximal humeral head with the whole heel of your hand. Is that it?
Yes.
Perfect. So gentle pull for a distraction, and then my mobilizing force is right here. Direction is not straight posterior, but rather posterolateral. Just like with MMT, we were looking at your forearm to determine direction of force. That's how we figure out which direction you're pushing here. Your forearm should be oriented in a posterolateral direction. Turn in a little bit just to try to keep him nice and supported, but unweight the joint just a little bit. Add a little bit of separation. It doesn't need to be much. Try to find the most proximal aspect of the humeral head. Whole heel of your hand on it. And then remember our grade 1 oscillations. Small amplitude, just a little vibration there. Mr. D, you good? Front of your shoulder good?
Mm-hmm.
Okay. Grade 2, a little bit bigger. You'll see his body moves a little bit more. Just a bigger amplitude. And in both cases, I'm posterolateral, not just posterior. Whereas before, my direction of force was posterolateral. Now I'm just going to take fingers in my hand, sink through the soft tissue of the posterior shoulder, and my direction of force is anteromedial. Again, slight distraction and anteromedial force. Tucked in nice and tight. Again, if he's making a fist or if I feel the Yeah, if I feel any of this, I'm like, okay, nothing I do is going to overcome the rotator cuff force. So I need to make sure he's nice and relaxed. Gentle distraction. Just unweighting the capsule so that we don't bang into now the anterior rim of the glenoid. We're not going to push posterolateral this time. Instead, we're going to sink through the back of the capsule, back of the shoulder, and our force is going to be in the anterior direction, anteromedial. Now, this is, I think, the first time we'll get to talk about this. We're not just going to compress the soft tissue, right? There's actually no shoulder movement here if I just squish the posterior delts. There's a lot of movement, like in between here and here, but all I'm doing is squishing his posterior delt. Make sure you sink through all of that. And at the point you've sunk through all of that tissue, now our force begins. Nod. All that. Other thing to think about now, force, your amplitude. Grade 1, just little vibrations, right? Early in the range, really small. Grade 2 would be a little bit bigger, still early in the range of motion. Those little oscillations, because the arrow goes both directions, those little oscillations can help to further right in between. I'm not here for the fourth.
I'm starting with therapist position, right? Stand lateral to the patient's arm being treated and support the forearm between your trunk and elbow.
Same support, same cradling, just now with my other arm.
Yeah, place one hand in the patient's axilla to provide a grade 1 distraction.
You might not get to the axilla, you might have to provide that little distraction from the epicondylar region, that's fine as well. Try not to pull in the skin, instead grab the epicondyles and just kind of give it a little bit of a force out away from the body.
The web space of your other hand is placed just distal to the acromion process.
Is the mobilizing force
Yes.
next? Yes, one more point.
Mobilizing force. With the superiorly placed hand, glide the humerus in an inferior direction.
Thank you.
Lovely.
So, sounds great. Looks great on a skeleton. You'll see in a minute this is really hard because you're either on the acromion or you're falling off the arm, right? There's just not a lot of space to contact the bone. Even if your shoulders are really broad, it's muscle tissue. It's generally not going to be a larger humeral head. So this sounds great. It looks good on the skeleton. A little harder on a real person. So I'm going to show you a second way to do this that we prefer. Patient position is like this.
Okay. With the patient supine, stand facing the patient's feet and stabilize the patient's arm against your trunk with the hand furthest from the patient. Slight lateral motion of your trunk provides grade 1 distraction via a long axis traction.
Perfect. So somehow we are trying to gently create a little bit of distraction here, just like with our other slide glide techniques. The text says just lean back a little bit, the trunk rotate to the left, just pull on the epicondyles. Either way, we're just trying to unweight the joint a little bit so that our force allows us to move freely and not bang into the inferior lip of the glenoid.
The next one is sitting.
Don't skip over that. Thank you. You're on point with just reading. I think you're that person.
Thank you.
Yeah.
Yeah. I think, yeah, no. And then the next one is that. Is that what you have?
Yes, the web
Okay.
space.
Place the web space of your other hand just distal to the acromion process on the proximal
Let's
humerus.
pause there. Can we appreciate how much easier it is to contact the humerus here? There's so much exposed past the acromion, whereas here, it's like acromion and then nothing. Once we're abducted, now I can really contact the humeral head and not slip off. Good.
Mobilizing force. With the hand on the proximal humerus, glide the humerus in an inferior direction with respect to the glenoid fossa of the scapula.
I'm a man of the people.
Mr. Perez. Woo.
So all of the other ones, I was right here, nice and supported. For this one, I'm just shifting my position a little bit. I'm still contacting his arm in all the same places, right? It's cradled here. The text says axilla. I can't meaningfully reach, but I can get to the epicondyles to provide a little distraction force. So for one, if the arm can't abduct all the way to the side, this works just fine. Incidentally, if you feel like as you do this, you're getting a lot of scapular movement, we agree. Like, not necessarily the most effective technique. If you're able to abduct, and try not to abduct from an internally rotated position, make sure you keep the arm supported in a little bit of external rotation. If you're able to abduct 90 and provide that little bit of attraction or distraction force, find the acromion, move just off the edge of the acromion, and then we're going that direction in our force arm. We're looking at your forearm to help us distinguish which direction is your force. A lot of soft tissue here. Make sure you're not just compressing the soft tissue. We're sinking through all the soft tissue, and then our force comes there at that point. Questions about